Welcome everybody to the April 29th pre-derby grand rounds, which is typically given by the chair, and I'm very happy to give a pre-derby grand rounds, and you'll find out pretty soon. I'm going to talk a little bit about C. difficile, gut microbiota, and our mammalian friends. And my disclosure is I don't have any industry disclosures, but I do have a disclosure about the practice of GI. I can tell you in my entire career, nothing has excited me more than seeing people who are almost going to die from C. difficile get an FMT and get better in a couple of days. It's the most dramatic treatment I've ever seen. I want to thank Forrest Arnold, our hospital epidemiologist, for case number 1, Dr. Barve for case number 2, and the first published case in Louisville of FMT in 2013. I'm going to thank our farm animals and scientific study for clinical case number 3. And for audience participation and amusement, I've got some challenge questions. And I'm going to start with the residents and fellows. If you look at Proceedings of the National Academy of Science from December 22, 2020 as one of the references, you might get one of the challenge questions. Your objectives today is we're going to review the epidemiology, pathogenesis, and burden of C. difficile infection in the United States, update on medical treatments, including antibiotics, a little bit about probiotics, a lot on FMT, and very little on immunotherapy. We're going to review the important functions of the gut microbiome in health and disease, and I hope to demonstrate to you on this pre-derby lecture analogies between vet medicine, mammals, and man. So we're going to start with your mammalian microbiota knowledge. And these are the questions I'm going to ask you at the end of the talk. Which species did we first use FMT for C. difficile cure? Which species is transfaunation regularly practiced? Is coprophagia common in horses? And lastly, why do wild giant pandas frequently roll in horse manure? So if you want to take notes about the clinical cases, because I'm going to introduce them and then I'm going to tell you what happened at the end. But clinical case number 1, and these are real cases, real people, not made up. This was a 60-year-old man, had chronic hepatitis C, alcohol abuse, and he was recently diagnosed with renal cell carcinoma. He got electively admitted for a nephrectomy. Post-op, he was complicated with hypoxia, acute kidney injury, MRSA, and treated with linezolid and levofloxacin. On hospital day 6, he developed profuse diarrhea. His stool was positive for C. diff, white count extremely elevated. He was hypotensive, tachycardic, febrile. His abdomen was markedly distended, and he had hypoactive bowel sounds. CT of the abdomen had dilated air and fluid-filled thick-walled bowel loops and was consistent radiographically with toxic megacolon. So colorectal surgery was consulted for emergency colectomy. That's case 1, emergency colectomy. Case 2, a female, also elderly at 75 with NASH cirrhosis, ascites. She had a history of recurrent C. difficile due to multiple hospitalizations and was on antibiotics off and on over 4 months, now admitted again with greater than 10 watery stools, profound weakness, tender abdomen. She was febrile, hypotensive, tachycardic, high white count, in renal failure. Abdominal plain films had featureless loops of fluid-filled bowel. There was no free air. She had no peritoneal signs. She was treated with oral vancomycin, high dose, metronidazole, Fluorostor, which as you know is Saccharomyces boulardii, and cholestyramine to bind the toxin. That was case 2. Case 3 is a community acquired, something happening much more often now, at least 25 to 30% of cases. 83-year-old female golfer, avid bridge player, healthy except 1 to 2 times a year. She would take Septra for a UTI. She acquired C. difficile, had diarrhea, weight loss. She failed metronidazole, and then she was treated successfully with vancomycin, but then recurred again. She didn't want to pay the insurance copay for Difficile, which was $2,000 from Medicare, and she refused FMT by any route. She's never had a colonoscopy and refuses to ever have one. She tells you this is the worst illness ever, and she's really depressed because she doesn't want to transmit the illness to her family and friends. She's a clean freak and cleans her house with bleach every day. What do you do for her? Those are the three cases, three real people. So C. difficile is a beautiful gram-positive rod, and the spores are also very beautiful on EM. They're very resistant, they're very abundant, ubiquitous in nature. They can live for up to 6 months or more on hard surfaces. The health burden in the United States is such that C. diff is the leading cause of nosocomial infection. And again, community-borne outbreaks are also on the rise. The population can have these bacterium as commensals, and in fact, about 70% of infants have C. difficile, but they're asymptomatic, and that could be due to lack of binding toxin receptors. There's a rising prevalence in our community. We don't exactly know what that evidence is because it's not a required public health reportable disease. But we know that with broad spectrum antibiotic use, poor infection control, immunocompromised folks, and now emergence of some resistant strains, C. difficile is a big problem. In hospital setting, it's acquired in about 13% that are hospitalized for 2 weeks, 50% for those hospitalized more than 4 weeks. And you all know with seeing these people in the hospital, if they've been treated with antibiotics, the recurrence rate is 20 to 25%, particularly if you use metronidazole. And this increases to more than 40%, then more than 50% with subsequent recurrences. PPI doubles the risk of C. difficile infection, so does H2 receptor antagonists. Now, you might remember that C. difficile is, quote, acid resistant, but that's not why acid suppression doubles the risk. Acid suppression hurts other commensal organisms that probably help prevent C. difficile. So it changes our microbiota. PPI is not good for our microbiota. The spectrum of disease from C. diff, mortality rates have risen over 400% in recent years, 500,000 cases a year, something like $5.4 billion spent, and 15,000 deaths annually. Most of the infections occur most of the deaths occur in people over 65, just like COVID, but half of the infections occur in persons less than 65 years old. And the spectrum of disease varies. They may have lingering mild diarrhea to dehydration requiring hospitalization, with toxic megacolon being the most severe complication. Its incidence is fortunately low, however, very high mortality without surgery, and about half of the patients who go to surgery die despite having surgery. We know we send stool and we look for cytotoxin A and B. If they don't have cytotoxin, they probably don't have invasive C. difficile. CT scan hallmarks include bowel wall thickening greater than 4 millimeter is sensitive and specific. We don't have sniffer dogs. We have therapy dogs, but there are dogs that can be trained, and patients will tell you when they get C. diff back, they can tell because there's a characteristic odor. PCR has been available since 2009, but remember it can be positive for months after the diarrhea is resolved. So you have to have the presence of the cytotoxin to know that that particular course of diarrhea is related to C. difficile. Radiographic findings, the picture on the left shows a Mercedes sign. That's where you can see a little bit of contrast in this very otherwise thickened bowel wall. The bowel wall in the colon is only supposed to be a couple of millimeters thick. The plain radiograph over here, this is pointing to the thumb printing that you see. Endoscopically, it looks like pillows of yellow mucousy junk, and then pathologically, you see polymorphonuclear lymphocytes, the volcano appearance where the epithelium has been denuded. So what happens in a person again? They have risk factors, advanced age, they've had surgery, they've got inflammatory bowel disease and already have breaks in their mucosa or they're immunosuppressed. They've been on antibiotics. They may have abnormal microbiota or disturbed other commensals, and so they have propagation of C. difficile toxin production. You can go two ways. You can resolve with having an effective response. You can be asymptomatic carrier, or you can have an inadequate immune response, have diarrhea and colitis, and recurrence is very common in that group. In the lumen, we don't know a whole lot about what goes on in the lumen. We know that we have bacteria working together or working not together. We have bile acids, and we have host immune responses. Again, in most people, the spores travel through. Sometimes they propagate, particularly if you have altered microbiota, and then they can invade and cause the diarrhea. Many antibiotics are associated with predilection towards C. difficile, and many that we use very commonly. There are some that are uncommonly associated, but all bets are off on people that have recurrent antibiotics. If Forrest Arnold were given this talk, he would talk a lot longer about infection control stewardship and C. difficile prevention. It is very important. When people come to the hospital, they should be tested. If they come in with a diarrhea diagnosis, they need to be isolated. If we transfer them to a nursing home, we need to let the facility know. We should wear gloves and gowns and discard and follow appropriate infection techniques, which we're better at now because of COVID. Hand sanitizers and hand washing is not adequate. That's one thing that's important to know. You have to use an EPA-approved spore-killing disinfectant or a pretty high bleach concentration to actually kill the spores on hard surfaces. So unfortunately, hospitals get colonized. It's expensive and a new technique, but UV disinfection should be where we should go. And you can put that in several ceiling lights, and you'd have much reduced C. difficile. And again, reduce antibiotic use whenever possible. If you do all of these things, probably you can reduce transmission by about 50%. That's transmission. You still have to deal with the fact that if a patient has altered microbiota, they're at risk. You all remember that we now have the capability scientifically to catalog the genes and species with rapid throughput DNA sequencing. And this project's been going on for over a decade. We now know what the major phyla are in the GI tract. We know that Bacteroides and Firmicutes are the good guys, and there are lesser of the bad guys. It's important to also know that our microbiome, what we carry inside our gut, is about 10 trillion cells, and that's about 10 times more cells than all the other cells in our body. So we're not really us, we're really us plus them. And people who are in balance have what's called eubiosis, and people who have reduced load or species, less diversity of their bacteria in their gut, have what's called dysbiosis. And there are specific diseases associated with dysbiosis. And no surprise, those include inflammatory bowel disease, metabolic syndrome, certain cancers, and obesity. So from top to the bottom, our stomach is an acid environment. pH can get as low as 1 to 2. And other than the contaminants in the drinking water, we should have very little bacteria in our stomach. If we take PPI, however, we're going to have more bacteria, and we're going to pass them into our small bowel. The small bowel is relatively sterile, and the diagnosis of small bacterial overgrowth, SIBO, is where we have more than 10 to the 5 colony-forming units per mil. As we go down to the colon, now we have billions of bacteria. And you might think these are bad guys, but they're not. They're responsible for digestion, absorption of carbohydrates, proteins, fats. Bile acids are involved with helping us absorb vitamins, and then water and short-chain fatty acids in the colon. So the functions in a nutshell of gut microbiota are providing mucosal immune function, providing an epithelial barrier, promoting motility, and nutrient absorption and metabolism. And the fifth one on the list that I find fascinating is that our microbiota modulate our behavior. And this is a new, you've heard of the gut-brain axis. Now it's called the microbiota gut-brain axis. And new literature with multiple animal models, which will allow me to now talk a little bit about animals. So if you ever thought that American studies were really intense, you ought to read this out of Scientific Report about horse behavior. And they didn't just take regular horses, they took horse athletes, dressage and jumpers. This was a study done in France. They had 185 horses. They observed them over 8 months. They had cameras in their stalls. They knew what they ate. They knew if they were on hay bedding or wood chip bedding. And they looked at their behavior. I found it interesting. They called that a compromised welfare is where a horse would develop a stereotype and become hypervigilant and aggressive. So they looked at how many times they bit and kicked and gave ugly horse face. And they also analyzed their stool, and they used some of the same techniques that we use. And they were able to isolate in horses certain bacteria that would confer with aggressive behavior. And they also compared this to some rat studies for the exercise part. If you put rats on a spinning wheel and you force them to run, they develop gut ischemia and they get sick and they have altered microbiota. If you just let them play and run around in their cage and do what they want to do, they don't develop that. So the conclusion of this study, and it was a fantastic read, is that intestinal microbiota are considered important metabolic organ with major relevance to horse behavior. They've, again, duplicated this in other animal models. Okay, so back to humans. What human evidence do we have that links microbiota to disease? Well, first off, there is a difference in the types of gut bacteria between thin and obese subjects. Post-gastric bypass patients' bacteria types change and become similar to thin persons. Toxic species increase inflammation in the liver with fat deposition, high cholesterol, and insulin resistance. So a lot of the talks that we give on NAFLD relate to the gut microbiota. Altered microbiota is associated with antibiotic use, pro-inflammatory and autoimmune diseases, and GI epithelial cancers. So showed this slide before, so has Dr. McLean. It has been done and validated by study that if you do a microbial transplant from a thin person, you can actually make a bigger person thinner, and you biochemically change their triglycerides and you lower their insulin resistance. So once we knew that FMT could be used, people started using it quite a bit in clinical trials for certain illnesses, certainly GI metabolic diseases that we've already talked about, and also some neurologic non-GI diseases, Parkinson's, autism, multiple sclerosis, fibromyalgia, and arthritis. And some of the studies showed improvement, some showed cure. So this isn't a new perspective. The historical perspective is quite interesting. A Chinese scientist, physician, Yi Hong, gave fecal suspension in the 4th century for diarrhea, and he called it yellow soup. By the 17th century, vet medicine used transfaunation. Now, transfaunation is not the same thing as fecal microbial transplant. Transfaunation is with ruminants, so cows and their cud. So a baby cow that wasn't doing well would get a cud transfer from a cow that was robust, and that would cure them. In World War II, the Germans observed North African Bedouins ingesting camel dung for dysentery, and that led to the use of a probiotic called Bacillus subtilis. It was in the late 50s. Eisman gave retention enema for pseudomembranous colitis. They didn't even know what C. diff was at the time. They just knew that pseudomembranous colitis was a bad thing. And then in '83, Schwann had a first case of C. diff treated with FMT. It took from then until 2013 for the FDA to approve C. difficile in the United States. Now, what is the evidence of C. difficile and FMT? What's the relationship? Well, first off, antibiotic-treated mice that were infected with C. diff developed chronic dysbiosis, and they had opportunistic bad pathogens similar to humans. By 2011, there had been over 376 human cases cured, 91% cured by FMT. And in these people, the C. diff recurrence was low, and microbial transplant seemed to persist. So that led to why the FDA approved FMT in 2013 was a randomized controlled trial. And it was actually halted because FMT was 3 times more effective than antibiotics in curing C. difficile. That was published in New England Journal. It was a small study. If you see only 16 people in the either one infusion or 2 infusions, but the cure rate is way above the antibiotic rate, whether or not you had a gut lavage before vancomycin or not. On the bottom, you can see also the healthy donors' microbial diversity is also improved after they receive a microbial transfusion, and patients before infusion had low microbial diversity. So what happened to us in GI is our phones were ringing. People wanted this, and they wanted it desperately. The technique, if you care, and I won't go over too much, but you need fresh stool. Anaerobes are devitalized in oxygen. So actually putting it in a small container, you can put it in the refrigerator, freeze it, label it. Then you'd bring it to the doctor, and we'd mix it under a hood with non-bacteriostatic saline and pasteurize it and filter it. And then we would give it to the recipients who would come for a colonoscopy. They would already have had a prep. They'd have stopped their antibiotics. And we sometimes gave them also loperamide so that they could retain their aliquot. And we deliver it with a syringe via the accessory channel, either putting in the cecum or the terminal ileum. Keep the patient on their back as long as possible. And again, the success rate of a single infusion for cure is 91%. And you can give it also via an NG or NJ, the success rate a little bit less with 1 infusion, but it's still a viable option, particularly if you've got patients in the ICU on pressors that can't take a prep and have an NG in. So that's what we do usually in the hospital setting for severely ill people. The logistics for donors are that it's expensive. It's at least $300, may not be covered by insurance. It was FDA approved, but the doctor or the patient must know the donor, and they must get informed consent. The FDA required that you still called it experimental. They still require that today, and that outcomes are uncertain, and that possible transmission of infectious agents is possible. If the patient knows the donor doesn't have to accompany the patient to the procedure. Unfortunately, FMT is still not readily available in the community. Now, I'm going to bring this up now, and I'll talk about it a little bit more. Patients are performing transplants on each other, including for non-FDA approved diseases, because they read and they get online, and social media and public desire for self-treatment has led to many patients giving themselves, their neighbors or their friends, stool transplant for all kinds of reasons. So talking about this, since I said earlier that metabolic syndrome can occur, so if you were going to get a transplant, maybe you don't want your husband or wife to give you the transplant. Maybe you want this guy down here, or somebody like Brandon Worth, who's really thin. So donors have to be treated, have to be screened for all kinds of infections. We exclude a donor if they've had cancer or high-risk behaviors, body piercing, etc. We exclude healthcare workers because we're probably colonized. And the chronic constipation link is, as you know, chronic constipation may be a marker for Parkinson's in later life. So we really want really healthy people as donors. We don't really know what to do with food allergies, IBD or IBS, but they're generally excluded as donors. What we have today, there's a company called Open Biome. So this idea of stool bank is not theoretical. We have a large company. We don't have fecal yogurt left. I think that would be better if we could isolate and create something for people to take. So let's talk about our cases. Remember, the first case was the male who came in for an elective nephrectomy, and he had post-op C. diff. He was hypotensive, and he had toxic megacolon. He went to emergency colectomy with ileostomy because he did have peritoneal signs. He was kept on antibiotics anyway. Unfortunately, he had a long, protracted course. He was eventually made a do not attempt resuscitation, and he expired on day 23. Now, our 75-year-old female with NASH cirrhosis and recurrent C. difficile had pseudomembranes. She did not have toxic megacolon. She failed a trial of fidaxomicin, probiotics, and Questran. Colorectal surgery opined that since she didn't have toxic megacolon, that her surgical risks outweighed the benefits. So what's her next best treatment option? What do you think we did? Of course, she received an FMT. The donor was her husband. What's so amazing in these patients, and again, that was my disclosure, they get better so quickly. They can come off of pressors in 48 hours. I mean, it's unbelievable. Her C-scope was normal at 2 weeks. The hardest case was the community-acquired case. The 83-year-old golfer, bridge player that refuses ever to have a colonoscopy or an FMT and has failed antibiotics. And she tells you this is the worst illness ever. So what do you recommend now? Nobody's saying anything, but my advice is talk to the animals, because the animal kingdom will give us the answer. If you let cows and pigs cohabitat, said the scientists who explained this to me, the sows don't get sow foot disease. And that's because cows have a high secretion of IgG into their GI lumen. We don't. Humans have IgA. So again, in understanding what goes on in the luminal environment between bile acids and bacteria and immunoglobulins, these scientists were able to extract the IgG from the beef and lysophilize it, and they fast-tracked it as a medicinal food for necrotizing enterocolitis in pediatrics, HIV enteritis, and I'm not kidding, IBS, irritable bowel syndrome, diarrhea predominant, where everything else came up negative. They also, on the box, recommend anyone with impaired capacity to digest, absorb, or metabolize food nutrients. So that's Interrogam, and that's what case 3, the golfer, got. She got retreated with vancomycin for 14 days, then an additional 14 days of chronic suppression, and she was given 5 grams of Interrogam for several months. I told her to take probiotics forever and limit antibiotics. I have a few patients that have common variable immunodeficiency, and I have them on Interrogam. They get C. diff over and over again, and they do very well with Interrogam. So thank you again to the cows and pigs that taught us a lesson for humans. Future challenges for FMT: should we give it orally? If firmicutes are needed to make the person's microbiota, that would require germination factors in the upper GI tract. So should we give it rectally? If bacteroidetes are needed, that they could be denatured in an acid environment. If we work and do more research to better identify the beneficial components within the donor microbiota, then we can match it with the recipient's disease. That would be the scientific way to do better than shotgun approach. And again, public opinion and do-it-yourself FMT should be recognized and addressed appropriately. In fact, this was an article published in the American Journal of Gastroenterology a year ago, April, understanding the scope of do-it-yourself fecal microbiota transplant. It was about 85 patients that had done this, and what caught my eye was reference number 4, Catherine Duff, the Fecal Transplant Foundation of Louisville. So I promptly called Craig McLean, and he didn't know about that, and I didn't know about that, and I started calling around, and basically the founder actually lives in Indiana, but she has a P.O. box that you can send donations to, and I think this may have come out largely because during COVID-19, FMT became very difficult to do. Basically, the stool bank companies were shut down. And so what do patients do? So there's a foundation if you want to support further research, but I think the important thing is understanding your patients are going to read online how to do a fecal transplant and do it to themselves. I have several patients that have come to me afterwards that have done this. So, pun is intended, is FMT one big crapshoot? Yeah, it still is. There's potential liability. There's potential disease transmission. I don't feel bad about performing an FMT in a 95-year-old that can't go outside and visit her friends because she has C. difficile and is afraid to give it to her friends. She's 95, and I'm not worried if she hasn't already developed Parkinson's that I'm going to give it to her with the transplant. But what do you do with the 25-year-old? Donor pool, again, we've talked about all of the obstacles there. And then, is it safe in critically ill patients with mucosal ulcerations or sepsis? I've already led on that we're doing that now, and there are case reports, not randomized controlled trials, but there's case reports of giving FMT to people in the ICU on pressors. And some of them live, and some of them don't, and we really need some randomized controlled trials. There are some targeted bacterial therapies, so some non-toxigenic C. difficile studies, hoping that they will occupy the niche and improve the ambient host bacteria. And so there was an original trial with 30% improvement in not recurring if they got the non-virulent strain. Unfortunately, just this February in the Lancet 2021, this was a 4-year study over 9,000 patients. We've been waiting for this vaccine trial. It was in 27 countries, and the study was halted for treatment futility. So it doesn't appear, so they decided they weren't going to continue this particular vaccine. So I say, be kind to your microbiota. If there's 10 times more of them than you, you've got to learn how to make them happy. And one way you can make them happy is by feeding them good stuff. So I am a believer in pre and probiotics for gut health. They do improve constipation, transit time, absorption of nutrients. However, there's no study that has convincingly determined a role for prevention for C. difficile. It's something we use to augment or add adjunctive therapy for people who've had C. difficile. So in summary, treatment for C. difficile infection, stop offending antibiotics and avoid antibiotics in general if possible. The treatment of choice antibiotic is now vancomycin, 25 milligram QID, higher doses and duration up to a month for recurrences, or you can switch to fidaxomicin, 200 milligram BID for 10 days. I do believe probiotics will be beneficial, and again, it's augmenting the microbiota, may reduce duration of diarrhea. Questran combined toxin A and B, and we frequently add that. We didn't talk a lot about IV immunoglobulin. Usually we give that to people that have common variable immunodeficiency. But we did talk about Interrogam, which is oral bovine IgG, and the only reason you shouldn't take it is if you are allergic to beef. It's becoming very popular, and we need more controlled trials to see really how efficacious it will be. And FMT for recurrent infection, so anybody that's had two infections or one recurrence, this is emerging as the best option, complicated though that it is. So if we were good learners, we would answer all of these questions. So let's see if we have discipline in our audience participation. You can yell it out, or Jason, you can tell me if somebody saw it wrote it in the chat. Which species did we first use FMT for C. difficile cure?
Don't be afraid to answer, everybody.
Okay, I've got some students I think that are watching. They better know this one. All right, I'm just going to say it. Yes, man, then horse, and now cats and dogs, who also get C. difficile, who also use FMT for their cure. Which species is transfaunation regularly practiced? Remember, 17th century, transfaunation is not, it's ruminants, so cows. So it's cud transfer. How about coprophagia? That's eating stool. Is that common in horses? We all know if you take dogs and horses and put them together, you're going to yell at your dogs for going and eating the horse manure, but you probably shouldn't yell at them for doing that. But horses, yes, foals between 2 to 5 weeks of age, they consume their mother's manure. And when they're in big pastures with other baby horses, they don't eat those horses' manure. They know their mothers. So I think that's very, very interesting. And the PNAS article, I thought this was just fantastic. Why do wild giant pandas frequently roll in horse manure? Mohammed, did you look that up? We told you yesterday you need to. He's not speaking up. He's down in the basement. So Mohammed El Masri, so you're in the basement. So the reason is they want to stay warm. There's a chemical mechanism in manure that contains beta-carotene, I can't even say that, oxide, which inhibits a cold activated ion. So these giant pandas have learned how to acclimate and stay warm by suppressing this ion by rolling in horse manure. I found that fascinating, and also that it made it to PNAS. So in summary, if Hippocrates did say all disease begins in the gut, and we think today he might say health is determined by the microbiota in our gut, Lawrence Brandt included that. And depending on your status, though, you may or may not want to order the yellow soup. Those are the end of my editorial comments. I'd love to entertain some questions.
All right, guys. If you want to ask a question or comment for Dr. Krueger, you can unmute your mic and do that. Or if you want to type it in the chat area, I will be able to read it for her. So everybody go.
Chris, this is Ashutosh. Great talk. Can you further elaborate as to what is the availability, medical availability of C. diff right now in the COVID times?
So Open Biome is back up and running. I believe that they are still using frozen specimens from pre-COVID, and you can get it within a day or two on compassionate use. I think all of us that have done FMTs think that is so much easier, because it is so much easier than identifying a donor and screening them. So really the identification of donors, if they don't want to go with a stool bank, is still something we can do, but it's more applicable to the outpatient setting where you don't have a hospitalized patient. You've got a little more time, because from, as you remember, Ashutosh, from getting a donor and getting them tested and then performing it, it's minimum probably 5 days, whereas
Absolutely.
you can get Open Biome. It's available again recently, and we're giving it, and you can give it per NG or per enema or per colonoscopy within 24 to 36 hours.
Thanks.
Mm-hmm.
Any more, more questions for Dr. Krueger? I don't know, Dr. Krueger. I think you explained it so well. There's nothing to ask.
I told Jason at the beginning that that is not the case. Okay, if people don't ask questions, they probably either didn't like the topic or it's too controversial and it's unpalatable. But I'm going to say again, It's the most impressive treatment I've ever seen. We can't scientifically explain it, so it probably makes a lot of the scientists extremely nervous. A takeaway, though, for pre-derby, again, is it's interesting when you read vet medicine and you see the correlations with human. I'm, there's this autism center that's beginning here. And honestly, if I was a pediatric GI doc, I'd be all over this, because the number of publications about behavior and the microbiota in the animal world are phenomenal. And there's right pre-COVID, I almost referred one of my friends who has an autistic son. There's a large clinical trial on autism and FMT, and then I'm sure it got halted because of COVID. But we may really see again whether we're smart enough to identify specific species that might cause altered behavior or altered mentation. That's going to take years and years of research. But again, to have treatments that this cures C. difficile in a dramatic way, and it is absolutely a crapshoot, right? So if we can further this research in the microbiota, and I know Gorbachi Sohi said at the beginning, are you going to bring this back to the heart? There's a lot to do with inflammation in the heart, right? We remember the years where people said, oh, if you have H. pylori, you're more likely to have heart disease. So any breaks in our GI tract that cause transmigration of bacteria, particularly bad bacteria, that implicate metabolic pathways, whether they're lipid type pathways or insulin resistance type pathways, things that drive inflammation, are likely going to be linked to a lot of other organ systems other than the GI tract, lungs, heart included. So we know the brain is included. So again, I think where we're going with microbiota research and technology is going to be applications to specific disease, and I think there's going to be a lot in the behavioral world. There's already papers out there about depression and anxiety cured with this. So it's just how brave are we? How brave are we not having the detailed scientific answer? And that's kind of like the art versus the science of medicine. If you're the foot to the ground soldier at the bedside, if it's your mother. So if anybody says, nah, I would never do that, this is just crap, I'm going to say, well, if your 80-year-old mother is miserable and would rather die or rather go palliative, and you go, well, would you try a fecal transplant? And then they got better and they're out playing bridge the next day. I think we can't be so arrogant about knowing the answers to the questions when it comes to curing bad disease if we have no other alternatives. So again, in the world of science, we want to know more. We don't want this shotgun approach, but it's kind of hard to argue with nature and with the observations of vet medicine and the application of the gut microbiome.
Chris, quick question. This is Dipendra.
Yes.
So, we know that colonoscopy and delivering the microbiome in the colon is the best route, but what's the data on your 90-year-old who refused a colonoscopy? I know for different purposes they've looked at studies where they either delivered it in the stomach or in the small bowel. What's your take or the data on that for C. diff?
It's about 84%. You and I both know that sometimes you have to give another round. So it's about 84% curative, giving it in the upper GI tract.
And I just wanted to share something as well, but there was a study that looked at, people lost weight by exercise and they auto-harvested their own poop, and they, if they fell off the bandwagon and they gained weight, they, gave that back, and then apparently they regained the benefit. So that was very intriguing.
Very intriguing, and it's kind of, remember we know in in obesity research studies with FMT that when people have lost weight, their microbiota changes. And there's also in the elite cyclist literature, this was an interesting study too. I'm blocking on the name of the organism, but there's a particular prominent organism that may infer an athlete with a better ability to extract nutrients so they can ride their bike or do their sport longer because they have this bacteria in their gut. So the same thing with that French horse study. That was such a profoundly detailed scientific study that they were able to confer specific organisms with docile horse behavior and aggressive behavior with other organisms, and it was pretty rigorously scientifically statistic. And also back to your athlete question and thin people, their bacteria changes. And again, maybe that's again to confer the host with the ability to extract nutrients for performance. I don't know. I find it just absolutely fascinating.
Chris,
We might come to a time where we store our gut microbiome when we're young and healthy, and then save it for.
Well, I've talked with oncology, and I think some Steve McClave has a question, but I've talked with oncology, and we've not done it, but I'd like to. If you had stored your own, because you can freeze it and keep it for years, if you stored your own microbiota when you were healthy, to your point, then if you ever had to be hospitalized, you can give your own microbiota back if you were hospitalized and got C. diff, or if you got graft versus host. So there are some interest and some trials in improving graft versus host or chemotherapy associated chronic diarrhea. Steve, you had a question.
Yeah, Chris, you had a reaction that I've had. I think you made the comment that this is the most impressive therapy you've seen. And that's the exact reaction I've had. These people don't even look like the same patient the next day. And what reverses is that toxicity and the SIRS response. And I've taken a step further. I've been fascinated by the use of fecal transplant in critical illness, because I think people come into the ICU with sepsis or trauma, and if the gut is not utilized or we lose the biodiversity within hours, the gut becomes an accelerator in that and makes outcomes worse and increases chance for organ failure infection. And I think a lot of the principles you've talked about in fighting C. diff could be used in critical illness to reverse the toxicity. And there are, as you allude to, some case studies where they literally change the whole way the patient looks as far as the SIRS response.
So I think, Steve, I appreciate that contribution, and I will tell you at university and also in Norton, it's usually the surgeons that are asking us to perform FMT. It's FDA approved for C. diff and nothing else, but in the original C. diff studies and most of the published cases, people aren't on pressors in the unit. But you and I both know we go up there and go ahead and infuse it in people who are on several pressors in the unit with C. diff, and it is the absolute most astonishing and dramatic thing when they improve very, very rapidly. So I think our medicine colleagues need to ask us to do the same thing. Now, whether or not we can extrapolate to just SIRS response in general with pneumonia, we would have to do trials on that, right? So, or you'd have to apply for an IND. Mm-hmm. So if you're going to go outside of the current FDA approval, you'd have to apply an IND and do a study. Yeah. And I think it should be done.
Jason, I have a question.
Yeah.
Generally speaking, in people who have diarrhea, their cholesterol levels go down. So we are careful what medicine we use. not necessarily related to your topic, but people who have chronic diarrhea, their LDL goes down because of absorption issues.
Well, you can have protein wasting enteropathy when you have diarrhea if you have a malabsorption problem, and you're right, you malabsorb fat. So if you have pancreatic disease or small bowel disease, so there are several, chronic pancreatitis, celiac sprue, even small intestinal bacterial overgrowth can present with diarrhea and weight loss and bloating, and I'm sure it'll alter their lipids as well. And again, whether or not that's the pathophysiology of, there's such a differential for diarrhea, Gorbachi. We usually try to identify, but it's a good point that you just don't think colonoscopy for diarrhea. Remember, the small bowel is where most of the action is going on. So if you have a patient with chronic diarrhea and the cultures are negative, they need an EGD and small bowel biopsy and small bowel aspirate for culture, and to determine what's going on. They may need fecal fat analysis. We forget about chronic pancreatitis can be insidious, and so there's a lot to it. How that goes back to the microbiota and whether or not it's causal related or whatever, I don't know the answer to that.
Can I ask a question? This is Julio. You alluded that the microbiota in some patients may be producing a chronic inflammation after the patient has an acute process. We see this in patients with pneumonia. Could you speculate? Now we are seeing the primary infection that we are seeing is COVID-19, and we know that after COVID, the patient remains with multiple medical problems, and there is this idea of chronic inflammation, and then we have all these post-sequela of COVID. Could you speculate on the possibility that this chronic inflammation may be due to the changes in the microbiota, and how will you design and study really to evaluate this in our post-COVID clinic?
So interestingly, if you have COVID-19 and you're hospitalized and you get C. diff, your death rate's 44%. There's that. And you also brought up what I've also noticed, but not been aware if there've been any robust studies. A lot of the C. diff GI symptoms affect motility, and they get prolonged ileuses, they get gastroparesis, they get actually constipated. So there's definitely your point that there's alterations in the microbiota with COVID-19, and that may drive a vagal response, that may drive all kinds of changes. So if I were designing a study in the post-COVID clinic, if somebody had chronic diarrhea or chronic constipation or inability to eat, that's what we've seen in hospitalized patients. They just can't eat and they vomit. And so we've had a lot of upper gut symptoms from COVID-19 GI involvement. You could make a good argument for doing an analysis of their stool and looking at what's in their stool, and we have that capability now. We can do it up here in the CTR. Dr. McLean's lab does it. Dr. Sharish Barve does it. So we could do that, and then you could make a good argument for doing a fecal transplant. I wouldn't know how else to do it, Julio, because we haven't identified, again, which of the bacteria. But I'm really happy that you brought that up, because the post-COVID literature is more and more talking about what? It's talking about neurologic changes and things like depression and anxiety and behavior related. So I think that big axis of the microbiota brain gut, maybe we have enough patients that we could do a clinical trial here.
Thank you.
Dr. Krueger, we have a question from Dr. Usef on the chat, and she says, do you have a diet that you recommend to your patients in general, DASH, Mediterranean, healthy heart, etc.?
I think if a patient's going to follow a diet and they need to, that's great. So I try not to dissuade anyone if they're following one that they like, and definitely eating less fat and processed foods I think is important. Incorporating exercise is important. So probably the Mediterranean diet is my favorite diet. Now, the American Mediterranean diet is not helpful because if you look at the Mediterranean diet, right, there's much less meat and it's more, grains every day. Well, our grains are enriched and have fats and sugars added to them. So it's very hard to extrapolate a true Mediterranean diet with, quote, an American Mediterranean diet. I do have a list, and I do talk diet probably with every one of my patients. If people want to gain weight, I tell them how to gain weight. I tell them to eat pasta and pizza and Mexican, and that's for people that really want to gain weight. I generally advocate for healthy fats like olives, olive oil, artichokes, avocados, salmon, that sort of stuff, and definitely variety. I think there's importance in having, whole fruits and vegetables. So I like the paleo diet. People seem to lose weight on that. When people go to the I tell my patients that want to lose weight, you go to the grocery store, yep, it's going to cost you more, but the savings will be important in the long term. Don't go down the aisles and put all these packaged things in your cart. Go around the periphery and get everything that's refrigerated. And that's generally what I tell them.
Dr. Krueger, the problem with the Mediterranean diet is a lot of fruit that it recommends sugar. Fruit has a lot of sugar. My wife likes to eat fruit and she forces fruit on me. I keep on telling her it's full of sugar.
Yeah. So the fructose story we could talk about also for a long time, and I learned a lot from Matt Cave and fructose and how during the Cold War with Russia, I don't know, it was in the I guess 40s, how all the teenagers started gaining weight because the American farmers couldn't export their corn anymore, and so they just boiled it down and extracted high fructose corn syrup and stuck it in everything, ketchup, all of your salad dressings, bread, everything. And so when you read labels, I tell my patients who want to lose weight, read labels, and if fructose is the first or second component, put it back counter. If you want to have ketchup, get ketchup with sugar. Get molasses. If you want to use pancakes and syrup, use real syrup. Don't use high fructose corn syrup. Get real maple sugar. And so and they lose weight. I restricted fructose from a friend's daughter who wanted to lose weight before her wedding to get into her wedding dress, and she lost 22 pounds in 2.5 months. And all she did was read labels and stay away from fructose. Now I have a bit of a different, I think fruits that are whole fruits are, there's not a lot of calories in an orange, just like 65 calories in an orange. And there's a lot of fiber and a lot of water. So I think that's much better than drinking fortified orange juice or things that put syrup in it. So just get rid of high fructose corn syrup. The only time you can do it is if you're exercising. Fructose is important if you're exercising. Endurance athletes will know. That's when you can drink a Coke that's got fructose in it because you actually need it and you can use it right away. Otherwise, per our Krebs cycle, fructose is treated by the body as a fat and rapidly converted to fat. unless you need it immediately for that energy cycle. So it doesn't always enter and get metabolized. So even though it's called a sugar, our body treats a lot of it like a fat and stores it as a fat. We've gone over the hour, but I'm so excited about the questions. Are there any more before we hop off? Oh, that was perfect. A dog barking is perfect for ending my animal mystery talk today. And thank you very much, everybody. Have a great week.
All right, and thank you again, everybody. Thank you, Dr. Krueger. Outstanding as always, and we really do appreciate it. And thank you, everybody, for joining. Had a great crowd today, and we will be back next week, same time. I believe it is May 6th, and our subject will be involving infectious diseases. So we hope to see everybody there. And just one quick, we will just really quick, we'll mark your calendars for May 27th. I believe we will be doing awards day this year virtually. So that will be May 27th. It'll be virtually, but at the same time, Thursday morning at 8 a.m. So thank you again, Dr. Krueger, and thank you everybody for joining us. We really do appreciate it.
Bye. Go hug your horse or your dog.
Definitely.